This lecture is about diabetes mellitus, and we're really looking at a brief review, looking through the lens of a primary care provider, and maybe the most important thing I share are the new 2019 standards of care from the American Diabetes Association. So, as a matter of review, we know that diabetes mellitus is a group of metabolic diseases. It is characterized by elevated glucose resulting from defects in either insulin secretion or insulin action or both. Type 1 diabetes is the autoimmune destruction of the beta cells within the islets of Langerhans in the pancreas, and those individuals are genetically predisposed. Type 1 contributes to insulinopenia, so low insulin if no insulin, and just lifelong dependence on exogenous insulin. And you can just take that to the practice bank because our type 1s need to be treated with insulin. More rapid progression in infants and children with type 1 than in adults, and certainly the majority of people with type 1 are infants and children, but you will see it in adults also. Type 2 diabetes is a metabolic disease with an insidious onset. There is progressive insulin resistance, and when you begin to contemplate prediabetes and metabolic syndrome, you're really thinking, okay, this is the profile: abdominal obesity, insulin resistant and hyperglycemia, elevated triglycerides, and low high-density lipoprotein levels, elevated blood pressure, and really markers implying a pro-inflammatory state. And you're looking at those markers through serum analysis. The epidemiology of diabetes is scary. It is the most common metabolic disorder in primary care and the leading cause of cardiovascular disease, renal failure, blindness, and non-traumatic limb amputation. Our textbook gives us 2012 data, and I'll be able to update that in a few minutes. But look at those numbers. 9.3% of the U.S. population were diabetic in 2012. Unfortunately, 8 million were undiagnosed, and 86 million are thought to be pre-diabetic. There is, after age 20, there's a slightly higher incidence in men, 13.6 versus women, 11.2 to become diabetic. But we do know that diabetes prevalence increases with age. I also want you to take a moment to look at our Americans from different cultures and see the distribution of where you see the most diabetes. That last fact, 90 to 95% of the U.S. diabetics are type 2. The pathophysiology or pathogenesis, really, again, about that type 1, we understand that autoimmune destruction of the beta cells within the islet of Langerhans, and these people are genetically predisposed. The pathogenesis of type 2, for many years we've practiced knowing that there's decreased glucose uptake, increased hepatic glucose production, and impaired glucose secretion. However, recently a newer model, the ominous octet, came and said, yes, I agree, those things are happening, but there's 5 other things that we know happen within the type 2 diabetic, and that is increased glucagon secretion, increased glucose reabsorption by the kidney, and increased lipolysis. So, and then the 7th thing is decreased incretin effect, and finally, neurotransmitter dysfunction of the brain. So, very complex. Clinical presentation of a type 1 diabetic is usually acute symptoms of the 3 Ps, the weight loss, blurred vision, fatigue. We might see that also followed by increased glucose in the urine, nausea, vomiting, abdominal pain, rapid shallow breathing, hypotension, and dehydration. And that's all reflecting those signs of ketoacidosis, which is a medical emergency. And often our type 1s present that way. Type 2 might have no symptoms initially, then they're eventually going to experience that increased thirst, increased urination, blurred vision, fatigue, slow wound healing, frequent infections, increased hunger, weight loss, and tingling of the hands and feet from peripheral neuropathy. So look at the physical exam parameters, really head to toe everything. A thorough history, review of symptoms, past medical history, family history, medications, diet. Really, the screening is very thorough neurologically, eyes, derm, thyroid, cardiac, and abdominal exam. And we do individualize those physical exams and bringing them into the clinic. Type 1, you can anticipate they're going to be until they're regulated. And then maybe every 6 months, maybe if they're very well controlled. It could range from daily to every 6 months. So it depends on when they were diagnosed and how compliant they are or how fragile they are. And then definitely when the glucose is regulated, that will be definitely a objective sign for you. Diagnostically, it is the diagnosis criteria for diabetes based on the glucose threshold, above which the risk of retinopathy is increased. So we know that hemoglobin A1C of greater than 6.5, a fasting plasma glucose greater than 126, or a 2-hour plasma glucose level of greater than 200 during an oral glucose tolerance test fulfill the criteria, the diagnostic criteria for diabetes. And screening sometimes will involve, and often when you're trying to differentiate between type 1 and 2, C-peptide level and those markers in type 1 of islet cell autoantibodies, insulin autoantibodies, and those GAD65 autoantibodies. And that really will differentiate the type, because sometimes it's difficult to differentiate when you have those type 2 coming in ketoacidosis. So the differential diagnosis is really limited to type 1 diabetes, type 2 diabetes, or diabetes insipidus. And it is those differentials until proven otherwise. I know that our text has listed all these other reasons, but these have to be eliminated. Management is things that we are familiar with: healthy diet, regular exercise, and medication. And look at that third parameter. I mean, the regime is specific to the type 1, insulin dependent, type 2, lifestyle change alone, or medication. And that could involve insulin, but they have many more choices. Type 1, it is insulin. Blood glucose, cardiac blood pressure, renal, endocrine, neurological, vision, and derm assessment, monitoring or assessment. All that is in their management, and there's parameters that the ADA gives us. Self-care education and periodic follow-up with the primary care providers and the diabetic care team. You know, it's interesting, that last part, the diabetic care team, I don't have a formal one in my clinic, but I had to put it together. And so putting that care team together, even if they're not logistically in the same place, is the primary care provider's responsibility. So getting that nutritionist involved, making sure they have an eye doctor, etc. So one of the things I did want to review, because we're really looking at the acute complication of diabetes, are those 4 situations when there could be acute complications. One is hypoglycemia. We have a definition that says it's glucose under 70, and it's caused by an imbalance of food, exercise, or insulin. But you all know that this can differ between diabetics. That's not a golden number. It's just a number that averages. So knowing the signs and symptoms of hypoglycemia and teaching those is absolutely imperative. The treatment of hypoglycemia is consumption of sugar. So mild to moderate hypoglycemia is corrected with 15 grams of carbohydrate. twice that amount of carbohydrate may be needed to correct severe hypoglycemia. And we do also recognize as nurses that liquids such as juice or non-diet soda can be consumed more quickly than solids. But if there's a risk of aspiration, glucose gel may be applied between the cheek and gum. All patients are advised to keep a rapid-acting carbohydrate. It's an excellent table on page 1089, table 206.3 on hypoglycemia, signs and symptoms and treatment. I want you to review that. So hyperglycemia, the extreme opposite, glucose levels above 180 or higher. And at 180, most people don't experience any symptoms. But with sustained hyperglycemia, there will be symptoms of increased thirst, urination and hunger, blurred vision, fatigue. And then we know that we can correct this. Treatment would be some rapid-acting insulin. Taking an additional dose of oral diabetes medicine is never recommended. And then really having them use their glucose monitoring system. Next is diabetic ketoacidosis. And if untreated, hyperglycemia can progress to diabetes, DKA as we call it, or even the HHS. But the DKA is caused by insulin deficiency, and it is characterized by hyperglycemia, ketonuria, and acidemia. And clinical presentation includes rapid development of abdominal pain, nausea, and vomiting, Kussmaul's respiration, and dehydration. These are the patients that may reveal a fruity odor to the breath, tachycardia, hypotension, changes in consciousness. This is a medical emergency. The most common cause includes new onset type 1 diabetes, omission of insulin, infection, illness, or major surgery. On occasion, you might be able to avoid hospitalization, but that is on occasion. You can look at on page 1090, box 20612, talks about ketone monitoring. So let's finally just look for a moment at the hyperglycemic hyperosmolar state, okay? It was previously called hyperglycemic hyperosmotic non-ketotic coma. That new term recognizes that patients may have altered sensorium without coma and may have mild to moderate degrees of ketosis. They are medical emergencies and require immediate treatment and in most cases hospitalization. I want you to reread those sections and know the difference between those 4 emergent acute complications of diabetes. So finally, I was looking at the American Diabetes Association, and I was wanting to look at standards, which I'm going to post in our weekly module, and I found the 2019 updated standards. And I just made a few snapshots of their PowerPoint, because look at that on that first one. The financial cost of diabetes in 2017 was $327 billion. That had increased from 26% in 2012, and I quoted 2012 out of the textbook. I also that second slide, 1 sample 2 test, it's a new parameter that says I can have 1 sample, do 2 tests, and I can diagnose diabetes. I can get a fasting glucose and a hemoglobin A1C out of the same sample. That's new. This is a nice algorithm on the decision cycle for patient-centered glycemic management in type 2. And then I also copied, because I learned something, interfering substances when you use your glucometer. If they have these conditions or are taking these medicines, it interferes with their glucometer readings. And I did not know all those until I watched this presentation. And then the last 2 is just some algorithms of treatment, okay? My point was to get you so excited that you would go on and watch this 30-minute, it's 26 minutes actually, and you get 0.5 CNEs. I did it today. And